Welcome back everybody, David here again with Med School Bootcamp. So in this next chapter, we are now going to turn our attention to some inflammatory conditions and malignancies of the bladder and the urinary tract system. So throughout this chapter, we're going to talk about the difference between cystitis versus pyelonephritis and the different types that can be present for a patient. We're going to talk about some malignancies, including RCC or renal cell carcinoma, renal oncocytoma, nephroblastoma, and a couple different types of bladder cancers, including urothelial carcinoma and squamous cell carcinoma. So there's a lot to unfold, but if you all are ready, then off we go. So first we're going to talk about something called acute cystitis. Acute meaning it's a pretty rapid onset or a pretty recent finding for the patient, recent symptoms. Cystitis is actually broken up into two key points. Cyst meaning bladder, and itis referring to the actual inflammation. So altogether we have cystitis, which is inflammation of the bladder itself. I also want to point out that we typically break up the urinary tract system into the lower urinary tract system, which typically includes the bladder and urethra, and then we have the upper urinary tract system, which typically includes the kidney and the ureters itself. So when we talk about cystitis, we're specifically talking about lower urinary tract system, or a lower urinary tract infection, because cystitis is referring to the bladder. So we're most commonly talking about the bladder portion. This is important because in a future video, we're going to talk about pyelonephritis, which is what happens when bacteria ascends into the kidneys themselves. So distinctly different. We need to keep this terminology straight. Now, when we talk about the pathophysiology here, the idea is that bacterial ascends from the urethra to the bladder. So that is to say, if we have little bacterial molecules that actually make their way within the urethra, well, they can actually climb and get into the bladder, and then they can colonize the bladder as well. And that's what we talk about when we say we have acute bacterial cystitis. We're referring to bacteria that has gotten into the bladder itself and ultimately cause inflammation of the bladder, or cystitis, which we talked about. Now, the primary etiology of this is going to be most commonly a urinary tract infection. The most common one that I want you to remember is that of E. coli. Far and away the most common one. If they give you a question and you're unsure of the bacteria, test-taking tip, I want you to guess E. coli, because statistically you are likely to be correct. However, there are some special situations in which this would not be the best answer, but most commonly it's going to be E. coli. We also can look at other things like Staphylococcus saprophyticus. More commonly, this is going to present as a younger sexually active female, and they're going to give you some clues that would indicate that we're not dealing with E. coli. So they could tell you that a patient is presenting with classic signs and symptoms of a urinary tract infection, and then they tell you to do some labs, a urinalysis, and a culture, and it's negative for E. coli. So now you know it's not E. coli. You know it's not the most common type. Well, a second option that you could go with that's pretty reasonable is Staphylococcus saprophyticus. However, keep in mind there are a couple other things. Klebsiella is another cause of UTI, as well as Proteus mirabilis. And the key thing here, if you remember from our previous videos, is that this will create struvite stones. Remember, these are our staghorn calculi, which are essentially these giant stones that can form in the bladder themselves, which often need to be surgically removed. Now, it's really important that you know the risk factors for increasing someone's chances of getting acute cystitis or a urinary tract infection. And I've broken it up into two categories here because we have anatomic risk factors, but we also have some other risk factors as well. So the first anatomic risk factor I want you to know is that having female anatomy due to the shorter urethra increases the risk of urinary tract infections, thus increasing the risk of a UTI. Now draw our attention back to our bladder diagram over here, right? If there's a fairly short urethra, bacteria doesn't have that far to climb to get into the bladder itself. Now, with male anatomy, the urethra is much longer. And so now the distance that bacteria would have to go from entering the urethra here and climbing all the way up into the bladder is a longer path. It's harder to do. And because it's harder to do with the longer urethra, there's less chance that the bacteria successfully implants itself into the bladder, and thus there's less chance of a urinary tract infection, less chance of acute cystitis overall. Now, other anatomic things that should be considered are structural abnormalities. The two main ones I want you to know about are BPH and VUR. BPH is our benign prostatic hyperplasia, and VUR is our vesicoureteral reflex. Remember, in BPH, there is prostatic enlargement, which I'm drawing around the urethra. And because of this, the typical urinary process, right, where urine is created in the kidneys, comes down the ureters into the bladder, which is ultimately excreted through the urethra. Now, if BPH is present, there's an obstruction. So we have a difficulty with actually excreting urine from the body. Key point here that I'm going to talk about later is urine is actually protective, or high volume flow, high amounts of fluid and hydration is actually protective against UTIs because we're continuously flushing urine down through the bladder and the urethra. And if you continually flush urine down the bladder and the urethra, well, that's going to basically kick out the bacteria. It's going to push them out of the body. So as they're trying to ascend up one direction, you actually are counteracting that with urine flow in the other direction. And so anything that disrupts our urine flow leaving the body is going to lead to a higher risk of urinary tract infections and acute cystitis. Now, a similar thing occurs with vesicoureteral reflux. Remember, we're talking about an obstruction to urine flow. So typically urine flows through the ureters, through the bladder, through the urethra unobstructed. However, in vesicoureteral reflux, we're actually getting retrograde or backwards flow. So there's an anatomic problem where the ureter is typically connected to the bladder. And because of that, we get a bit of an obstruction, which can lead to retrograde flow or backwards flow. Well, what's that going to do for the bacteria? It's going to be helpful for the bacteria because now instead of flushing them out through the body, we're actually getting flow backwards. It's going back up the urinary system, and that's where the bacteria want to go. So that's why it's helpful for them in establishing their presence in the urinary tract system. Now, moving on to some other risk factors, we see pregnancy as a cause. Pregnancy entails a variety of hormonal changes throughout the body, and some of these changes can actually lead to urinary stasis or vesicoureteral reflux as well. Well, doing so for similar reasons that we just talked about is going to increase the risk of urinary tract infections. Another important risk factor to keep in mind is diabetes mellitus. And the reason is that these patients have significantly elevated blood sugar. We call it hyperglycemia. And the problem is that hyperglycemia can actually inhibit our white blood cells or our neutrophils, right? They can inhibit a process called diapedesis, which is the process by which cells move out of the circulatory system towards the infection. And they can also inhibit phagocytosis, which is the process by which the white blood cells actually consume the bacteria or the infection in the body. So we're essentially impairing our immune response when we have significantly elevated blood sugars, and that's why we're at a higher risk of urinary tract infections. Other risk factors are going to include things like sexual activity and catheter-associated urinary tract infections. And the reason is these are things that can lead to a higher risk or higher exposure of bacteria. So sexual activity is potentially going to lead to insertion of bacteria that's on the skin inside the body, giving it a place where it can multiply and establish its urinary tract infection. And additionally, a catheter or catheter-associated urinary tract infection is, again, a foreign object that can potentially be contaminated with bacteria that we are inserting inside of the body. Doing so is going to increase our risk of developing a urinary tract infection and cystitis. Now, moving on to the presentation here, a couple classic ones I want you to keep in mind, and that is suprapubic pain. So that is pain right above the pubic bone. This is in the area of the bladder, which is why this makes sense. Additionally, increased urinary frequency, urgency, and dysuria. So these are all your classic signs of a urinary tract infection. Somebody comes and they say, hey, I'm going to the bathroom more often. It's been a bit painful. I feel like I always have to go, and I'm kind of having this pain in my lower abdomen region. These are classic signs of urinary tract infections. Now, super key point I want you to keep in mind here is that cystitis is going to lack systemic symptoms. And what I mean by that is they're not going to be total body symptoms, right? We're not going to be dealing with fatigue. We're not going to be dealing with fever. And the reason this is so important and why I put a star by it, because this is what we contrast with pyelonephritis, which we will talk about more in our next video. Pyelonephritis is what happens when the bacteria actually ascends from the bladder up through the ureters and gets involved in the kidneys. This becomes a lot more serious, and that's where we start to develop systemic signs and symptoms. So always keep in mind when you're doing these questions, you might get these classic presentation signs in both of them, right? Cystitis versus pyelo. The key way to differentiate the two in a question is to say, okay, does this patient have additional systemic symptoms? Do they have a temperature of 98.6 or do they have a temperature of 101.5? That could be the differentiating factor in terms of what their actual diagnosis is. Another key differentiating factor is going to be that patients with cystitis will typically not have costovertebral angle tenderness. However, a patient with pyelonephritis is likely to have this CVA tenderness. Again, we'll talk more about that in the next video. Also keep in mind that while these are the classic presentations, these are not mutually exclusive, right? In infants, we might see an infant who is very fussy and not feeding well because the infant can't describe their symptoms to us. So those might be indications that they're having a UTI. Additionally, in elderly patients, sometimes questions will talk about this in the presentation of dementia or altered mental status. And so keep this in mind as well. Classic presentation we want to know, but it's also important to know that depending on the patient population, is this a young, healthy adult? Is this an infant? Is this a 78-year-old? Can change a little bit on how this presents overall. And so that's why it's really important to go to our next step, which is to get diagnostics. For the most part, acute cystitis is a clinical diagnosis. If they have the signs and symptoms, you can typically start treating them with antibiotics to relieve their infection. However, there are some other things you can do, and the best initial test is going to be the urinalysis. And the reason is the urinalysis gives us tons of good information. One, it can tell us about the leukocyte esterase. Leukocyte esterase is an enzyme that white blood cells have, and it would make sense to see this in the urinary sample, right? Because if we have an infection, we expect our white blood cells to be there as well. Additionally, a nitrite positive result indicates that we're likely dealing with a gram-negative bacteria that is able to convert nitrates into nitrites. And again, we expect this to be positive because the most common cause is a gram-negative bacteria, being E. coli. And finally, we would expect to see bacteriuria, which is to say we expect to see bacteria in the urine itself if we were to get a urinalysis, because this bacteria is likely what is causing urinary tract infection. Another test that you could get would be that of a urine culture. However, typically we're able to gain enough information from the urinalysis itself to make the diagnosis. Now, the term pyuria means that there's a presence of white blood cells in the urine, but there are a couple special scenarios in which we get something called sterile pyuria. That is to say there are white blood cells in the urine, but the culture itself looking for bacteria is actually negative. So we say sterile pyuria is positive white blood cells, but a negative urine culture. And if that occurs, there are two key bugs I want you to keep in mind, and that is that of Neisseria gonorrhea or Chlamydia trachomatis. We'll talk more about this in our microbiology section, but the idea is that these particular types of infections do not gram stain well, so we're not able to actually see them on the urine culture, even though they might be present in the urinary system causing symptoms. And finally, another key point I want you to keep in mind here as it relates to contrasting with pyelonephritis is that we typically have a normal serum white blood cell in acute cystitis. Again, we don't typically think about systemic symptoms here. Contrast this with pyelonephritis, we'll talk about next, in which we would typically expect to see an elevated white blood cell count in the serum. And finally, moving on to our management options. So we're going to treat acute cystitis with a variety of different antibiotics. We have a couple different options here to choose from: TMP-SMX, nitrofurantoin, or fosfomycin. However, if the patient comes back to have a Candida-related infection or UTI, because there are a variety of different things, it's not just bacterial infections, you can get fungal infections causing UTIs as well. And if the question stem gives you that and says, hey, this patient had all of this workup, these came back negative, but additional workup showed that it was actually a Candida-related urinary tract infection, we're going to go to a different treatment option, which would be fluconazole. Now, I do want to mention a particularly tricky instance that could give you a question on referring to acute cystitis, and that is how we treat men for a UTI. And the difference is that we have to consider giving them a medication that can actually penetrate the prostate tissue itself, because oftentimes UTIs can hang out in the prostate and they can become a recurrent thing for the patient, or they can lead to another similarly related symptom called prostatitis. And so if they give you that type of question stem, then the best answer choice to choose from here is going to be TMP-SMX. So I put TMP-SMX is for men to penetrate the prostate tissue. Typically using some of your other options such as nitrofurantoin or fosfomycin are not going to be enough for these patients because it doesn't actually penetrate the prostate tissue itself. Now, in addition to treating these patients with antibiotics, we should also consider pain control, right? Because we know that this painful urination can be bothersome. And that's why we have a medication called phenazopyridine, which is a urinary analgesic. It can be used to help with symptom management as the antibiotics in the body work to clear the infection itself. And finally, to wrap up this video, we're going to talk about prevention here. We talked about how increasing fluid intake is going to decrease the risk of UTI. Why? Because we're continuously flushing the bacteria from the urinary tract system if we're continuously going to the bathroom. We also know it's important to be mindful of different ways that we can limit introducing bacteria to the body, so clean catheterization. And then for patients who have recurrent urinary tract infections, you can consider postcoital prophylaxis. Recurrent UTIs is characterized by greater than or equal to 3 different episodes of UTI with a culture-proven result within a 1-year period, or greater than or equal to 2 episodes of symptomatic culture-proven UTIs within a 6-month period. So if this is occurring, this is considered a recurrent UTI in which patients can be put on prophylactic antibiotics. So a classic vignette for this might be something along the lines of a 22-year-old college student is presenting to their primary care physician. They report signs of increased urinary frequency as well as some pain with urination, and the symptoms started about 2 to 3 days ago. And the patient does report that they've become sexually active recently. The clinician does a physical exam and notes that there's suprapubic tenderness present on the patient and orders a urinalysis to confirm the diagnosis. The urinalysis comes back with leukocyte esterate positive and nitrite positive results, and so the patient is started on an antibiotic course to treat their symptoms. So that's a classic way they will do that. That's a classic way they will present it to you. And there's a variety of different steps along that pathway that they can ask you a question. They can ask you what should they be treated with and give you some options. They could ask you about what lab you might want, which could be a urinalysis. Or they could ask you a microbiology question, say what is the most likely etiology for this patient. Given the context of the question that I gave you here, it would likely be E. coli. However, if they give you clues to indicate that it was not E. coli, then you would start to think about some of these other things that might be causing the UTI as well. So quick recap of this video: acute cystitis is a rather acute onset or new inflammation of the bladder itself. It's most commonly due to an infection of a variety of different causes, but E. coli is the most common one. Many risk factors, including both anatomic and some other risk factors, with the classic presentation being suprapubic pain, increased urinary frequency, urgency, or dysuria. We want to be mindful, does this patient have systemic symptoms? Because this is how we contrast this with pyelonephritis. When we're doing a workup for these patients, we can do a variety of different things. We can look at a urinalysis, we can also look at a urine culture, and potentially even using a bladder ultrasound if you suspect an anatomic defect. Dealing with management, we're really going to be focusing on treating the condition with antibiotics or antifungals, depending on what is causing the condition, and symptom management with pain control. But keep in mind, the best thing to do here and to educate patients on is ways that we can prevent this. A primary way to do this is to increase our fluid intake. However, we want to also consider our general hygiene by using clean catheters and other things that can introduce bacteria into the body itself. And for patients who have recurrent urinary tract infections, you can consider prophylactic antibiotics as well.